Up there. Hello, this is Howard Owens, publisher of the Batavian, with another live stream interview. For the first time, we're going to somebody outside of our community. I thought it would be interesting to talk to somebody involved in sciences and a scientist and is familiar with public health issues and the science around pandemics and epidemics and how viruses are spread or whatnot, a public health expert. And we have on the line right now Dr. Neil Abernethy. He is an associate professor of biomedical informatics and medical education at the University of Washington. His research is focused on public health, informatics, epidemic models, epidemiology, and in the context of global health. And he works on models related to things like COVID-19. He is not directly involved in, say, clinical aspects of COVID-19. So, Dr. Abernethy, thank you for taking time out of your busy schedule to join us today.
Happy to do so.
So first of all, one of the things we wanted to talk about was the main issue I thought would be an area of specialty, I think, for you, is explain for people better what contract tracing is and kind of what are the best practices for that.
Sure. So contact tracing can be used in various infectious diseases to when we have an infectious case that we, especially in a setting where we have a low incidence or low prevalence of the disease and a high severity of the disease, we can reach out to the contacts or community connections or social network, if you will, of that individual to see who they may have exposed, try to identify people who may be at high risk of acquiring infection, identify the level of exposure that occurred. If it was a one-time event, such as this recent choir that you may have heard of, where the choir got together and were singing, and lots of people got infected. And also to if we need to find those people for treatment and testing, to reach out to them individually, so we get their names, their contact information from the original case. Or we try to identify that through some other means, so we can follow up with those individuals to get them tested and treated.
So the way the contract tracing has been explained to us is right now the policy has been to talk to the individual who we know is tested positive, find out where they've been, who they've been with, anybody particularly within 6 feet, and then for public health officials to get in touch with those individuals, find out if they're symptomatic, put them either on precautionary or mandatory quarantine. Does that sound pretty standard to you? Is that what you'd expect? And are there other recommendations you have?
That's a great question. So the nature and purpose of contact tracing can change during the course of an epidemic. So at the very early stages, if we have a chance to keep an outbreak from spreading, it makes a lot of sense to intensively follow up on those initial cases to find out anything we can about how and when that exposure may have occurred. Was that person truly the first case, or were they infected by someone else? And have they gone on to infect other people? As an epidemic spreads, like COVID-19, if it gets really widely disseminated in the community, at some point there's a loss of return from that effort. And the public health agencies shift to the strategy of mitigation. We still do want to identify people who may be at high risk, so we can kind of focus on those individuals. But as here in Seattle, as hundreds of people are being identified every day, the resources simply aren't there to do a full contact investigation of every case. So we do then still collect information about potential exposures, so that if there are places like this choir setting, or if there was some congregate setting where, like a nursing home where people would be at high risk, we want to identify those exposures so we can still prevent the worst from happening.
So if I understand you correctly, what you're saying in these early stages where it's a small number to work with, try to isolate the people involved. If it gets beyond that, then really other aspects to trying to control the disease become much more important.
Sure. Well, and of course, if someone's symptomatic, we always want to isolate them. And in some cases, if if we expect a high burden of exposure, even if someone is not symptomatic, right now we're asking everyone to isolate because there are these reports of fairly substantiated reports of asymptomatic transmission, and there's a period where the disease may not have become symptomatic yet. So at this point, it's safer, and that's one reason we've gone to this national policy of isolation, is that there is such dissemination nationwide. Even if in some communities you're still seeing a small number of cases, very soon it's likely that there will be more than could be handled by a contact investigation.
Right. One of the things that's come up from our readers when we've reported on this, and social media comments and whatnot, is frustration over a couple of issues. One is the public health officials aren't releasing what city or town or village somebody might be from in our county. They're just giving a general idea of the part of the county. And two, sure, people are like, well, I want to know what businesses they are in or where they visited that day and see if I was there too. And the public health officials have basically, pushed back on that, saying, the real issue is you should be staying home. So that knowledge is not, there's privacy concerns why we don't want that out there balanced against you should just really stay home anyway. And so what are your thoughts on that?
Sure. There are a few concerns you raised, some of them privacy being one, HIPAA constraints on revealing too much about an individual case being another related to that privacy concern. Public health officials are very careful to make sure that we're communicating as intended to the population. We don't want to spread panic or fear. We don't want to tank someone's business that may have been an incidental place of exposure. There are, on the other end of the spectrum, there are some approaches, such as in Israel and I believe some in China, of actually trying to use cell phones and cell phone tracking from cell towers to try to notify people who may have been exposed. And there are proposals to do something like that here, but by through some automated message to send you a text message if you may have been in contact with someone. This is a kind of futuristic idea in the U.S., I believe, because of these privacy concerns. But one thing that the public health officials will do is that if there is a setting like a nursing home or a prison or some other congregate setting where there's just a really high risk, a school that may have led to increased exposure, there's a very high percentage of contacts that are coming back as positive, even a flight, on an airplane, then they would lean toward releasing that information so that people who were involved in that high risk exposure can self-report and call in to get checked on.
Okay, thank you. So I just want to throw in for anybody tuning in, this is Howard Owens, the Batavian. We're talking to Dr. Neil Abernethy. And one thing I want to mention before I forget it, I want to thank an organization called Science Line that is a nonprofit that hooks up journalists like me with scientists like Dr. Abernethy and make these interviews possible. You kind of touched on this already with what we know about transmission. And from what I've been reading, the general consensus seems to be that you can be infectious without being symptomatic, but that isn't totally settled science. That's pretty much what is widely believed. Is that your understanding? And what challenges does that make for public health officials dealing with an epidemic like this?
Sure. So there have been reports, especially coming out of China, where studies have been done of contact investigations looking at some exposures and trying to identify where those exposures could have come from. And so there do seem to be some pretty consistent signals that there is a substantial portion of people who are asymptomatic and that transmission is possible. However, of course, if you're coughing, you are going to be expelling more of those respiratory droplets that carry the virus. So for sure, someone who is symptomatic is going to be much more infectious. I do think more science is needed, more study is needed to figure out, just how infectious those people are, what really constitutes asymptomatic. Sometimes we'll experience a mild symptom that we won't consider illness. It's just like a simple cough a couple times a day, and we would normally go to work with that and not consider ourselves sick. So there may be mild symptoms or kind of borderline cases.
Good. It's my understanding that you can, like you said, just have a mild cough or even not even necessarily feel much of anything, especially if you're among the young and healthy. So one of the things the following state guidelines here is contact tracing is only going back 24 hours prior to being symptomatic for a positive test case. When people can be a carrier so much longer before they're being symptomatic, do you think that's adequate? Should we feel comfortable with that protocol?
I would feel comfortable with it, and part of the reason is, there are a couple of reasons. First of all, that you are more transmissible when you are symptomatic, and the viral load is increasing as you raised as the sickness progresses, and so viral load is also something that's the number of viruses in a sample. So the higher that viral load in your body, the more viruses you have, the more you can emit, and the more infectious you would become. So that's one reason. So you're kind of focusing on that window when people are most infectious. But the other is simply that we have to monitor or be careful with our resources with these contact investigations. Especially as the epidemic continues to spread, there will be fewer resources to spend on mild cases. So in kind of a related question, we've all heard about the concerns about testing capacity and some people being turned away from testing. If you call in and you have very mild symptoms and you're not, you're able to self-isolate, you might not be invited to come in to get a test because we need to save that testing capacity for the people who, are most needed for hospitalization or treatment.
I think that's a really good point. We've been hearing that a lot from public health officials of saving tests, and we hear, and I've seen comments from people on social media expressing frustration at not being able to get tested, but they're not in that high risk group necessarily, and so we're trying to save those resources. I wanted to maybe touch on what we know about means of transmission. I see a lot of stuff, bandied about on what might be the greater risk, whether it's aerosol, how long it might be in the room, how close you need to be to somebody, whether they're coughing or not, whether that makes a difference, and then versus touching things and how long it can live on surfaces. What do we know at this point?
Sure. So this is definitely an evolving picture. As recently as today, I've seen new scientific articles coming out trying to explore this question of, how far the droplets are spreading. So one thing to understand is that there is kind of a distribution of the size of the droplets that come from when we're talking or coughing or sneezing. Some are very small, and these can aerosolize and stay in the air for a really long time. And others are larger droplets. And so there's kind of a range. Those larger droplets tend to sink down either immediately or within a few hours. And they also tend to stay within that radius. So if you've heard about this 6-foot radius, those larger droplets are going to settle more easily within that radius. So even if you're talking to someone, that you're not getting that, it's only those smaller aerosolized droplets, of which there are fewer, that are going to hang around in the air. So just like, in a large glass of water, you have more volume. Those larger droplets are going to have more viruses, but the smaller droplets potentially can travel further. The issue is that several pathogens cannot survive in those aerosolized environments because they can desiccate and be exposed to radiation and so forth. So it's still an open question of whether the virus is surviving in these smaller droplets that can hang around in the air. There have been people actively studying this by sampling air. They have definitely found virus on ventilation areas near patients, even out on a ledge, near a hospital outside the ventilation. So there is some concern that there may be spread beyond, this radius that we're hearing about from the aerosolized smaller droplets. It doesn't hurt for people to take precautions, within reason. Certainly in Asia, they promote the use of face masks in the broader population. We haven't gone to that step here because it's not yet supported by science. But if someone wanted to take their walk around the block with their dog with a face mask, no one's going to, consider that a bad decision. So it certainly can't hurt if people want to take precautions. But we shouldn't panic that, we can't breathe the air around us when, as I said, most of the kind of volume of those viral particles are in those droplets. So certainly those droplets can settle on surfaces, and we do need to remember to sanitize those as well, especially high contact surfaces. So if you're in your home, you may be in your home with someone who's asymptomatic. You can clean the doorknobs, clean the kitchen counters and things like that, clean the refrigerator handle where people are touching things a lot. And just having a HEPA air filter in your house and, opening the windows from time to time will get some ventilation to clear out some of those droplets.
Well, that's great. That brings down another point I want to talk about. I don't know how much you looked into this, and I'm going to reference here a minute an article in I think it's the New Yorker magazine that came out by today, Siddhartha Mukherjee, and I'm going to apologize to my Indian friends for butchering that. He wrote a great book. He's not an epidemiologist, which he talks about in the article. He treats cancer. He wrote a great book, Emperor of All Maladies, which I read and really enjoyed, which is why I took to heart kind of this article. But it's all about viral load and how, looking at smallpox, measles, which are not the same as these disease, but there is evidence out there that viral load, and you've kind of touched on this, can impact how symptomatic somebody might become and how serious it becomes. What do you know about that? What can you address in that point?
Sure. So I've studied viral load more extensively in HIV, and in that setting, it definitely is related to the severity of disease and to someone's infectiousness. And so that's pretty much accepted science across a variety of diseases, that if your body is creating a lot of virus, if it's shedding a lot of virus, the word shedding we use for when you're emitting those viruses into the environment, into saliva and other bodily fluids. So that process, if you do have a higher viral load, that is a larger number of chances that those viruses have to infect someone else. So that is definitely a relationship that we care about. One thing that's maybe unsettled is, if we take a viral load sample, from a lung fluid sample, that might be different than the viral load we get from a nasal sample or from an oral sample. So, and there are rectal samples as well. There's a potential fecal oral route for the disease that is probably not the main route of transmission, but it's still being investigated whether it's possible that there's a fecal oral route for transmission of the disease. So in very unsanitary environments where people aren't washing their hands, there is the possibility that there could be transmission, but the different amount of virus that is present at different parts of your body is going to depend in part on how many of those receptors. So there's a receptor in our cells called ACE2, and the spike protein of a coronavirus binds to that ACE2 receptor. Different tissues in our bodies have different numbers of those receptors, and so we can have different viral loads, making us sick in one place and making another amount of shedding virus in another place. So there's still a lot we're trying to learn about this virus and how those relate to sickness and transmissibility.
Which brings us back to what we can do individually, maybe, and a couple of things I've read about transmission, and I think this relates to viral load. The way I'm putting things together is the importance of washing our hands and the ability, because you're picking up droplets when you touch other things, so you might have a higher viral load. I'm speculating and what I've read is that's why washing your hands is so important, doing it frequently, and not touching your face, because you perhaps transmit the virus more easily to yourself if you're not doing that. Is that a correct way of looking at it?
I will say that there's a potentially higher exposure if you if you've been in contact with someone with a high viral load, we don't usually use the word viral load, for something you've picked up on your hands from surfaces. But yes, if you've been around someone who is highly infectious and is shedding lots of virus, you can be in that kind of higher exposure environment, and that's one reason. Yes, it is very important to wash hands. Really, it's any time your mucosal environment, your nasal passages, your eyes, if you're wiping your mouth, these are ways that contact with those particles, if you pick them up on your hands, can enter the body. There's kind of another kind of high exposure environment, and that's in our healthcare facilities. And so in those cases, we often have patients with very severe disease who are being put on ventilators, sometimes being manually ventilated, and there can be emission of those particles at a very high burden, exposing our healthcare workers. So they're a particular population that we must protect, because if they get infected, that healthcare system that keeps everyone alive is going to kind of collapse. So it's important to realize they're not just contacts; they're very high exposure contacts to very sick people.
I think you raise a very good point. I'm glad you reminded people of that. And Zita Harthroth mentions this in his story. Some of the people who have died from this have been young medical workers. It's not just elderly, and they're getting potentially so much exposure in such a short period of time that it makes them particularly vulnerable, and we want to make sure they're safe. You kind of touched on this already, and I mentioned earlier, and I know this is not, from our previous discussion, not necessarily an area of your expertise, but the whole idea of mask wearing. I'm seeing, there's newspaper articles coming out about this more often, editorials, op-ed pieces. I think the Washington Post reported today that the CDC is looking at changing their guidelines this week on mask wearing. If we're thinking about the fact that you can be infectious without being symptomatic, and that if viral load is a factor, you think that maybe we should reconsider what the recommendations have been up to this point about widespread mask wearing? And I want to mention, by the way, I'm not recommending people go out and buy masks. There's lots of ways to make your own mask, but which will maybe be a subject of another post. But I wanted to just address that issue with you.
Sure. It's a great question. I think this it will be an evolving picture and discussion as we learn more about the virus, and as we continue our efforts to, as they say, flatten the curve. If those efforts aren't successful, we may begin to take additional measures to pull out all the stops and do everything we possibly can, even if it's a rare chance that you would get infected by an asymptomatic person. I think people could possibly do this selectively. So if you're going to the grocery store and you're going to be in close proximity to a lot of people, that's a chance for maybe 30 minutes. You just wear a homemade mask. We do, of course, as you suggest, we want to save those N95 masks for healthcare professionals. I had 18 sitting in my closet from the wildfires here in Seattle 2 years ago. I donated those to the hospital so that the people who really need them, have those perfect masks. I can use a bandana, or you can sew one of your own at home to save those good masks. So if you do have those hiding in your closet, your healthcare professionals do need those now. But I think there could be a role for broader wearing of masks, and it really comes down to your individual perception of risk and your individual exposure. So some people don't have a choice; they have to be out in public. Maybe you are the clerk at that grocery store, and you're going to be interacting with hundreds of people that day. I think it would be reasonable for such a person to ask their employer to provide some protection. And again, if you personally feel, anxiety, and we often overlook the mental health challenges in an unusual circumstance like this. If you feel that anxiety and it makes you feel better to wear a mask, then wear a mask.
That's great. I'm glad to hear you say that. I think one of the things we're going to have to do as a society is get over any kind of social stigma associated with it as we change. And the other thing I wanted to touch on, because you mentioned having N95 masks because of wildfires. And I know some people on the East Coast where we don't have those kinds of wildfires. I'm originally from California, so I understand, but people don't understand what it's like out there. And so there's a lot of confusion when companies like Facebook and other Silicon Valley companies were releasing like 1 million masks to public health workers because they had them stockpiled. Well, why is Mark Zuckerberg stockpiling masks? Well, it's because of the wildfires. A lot of people don't understand. Dr. Abernethy, I appreciate your time. Is there anything else we didn't touch on that you think we should cover?
Sure. Just one thing, and that is I mentioned very briefly earlier the idea of ventilation, and I think that's one thing that's maybe been missing in our public health conversations is the importance of good ventilation. I have been a TB epidemiologist, so tuberculosis. One of the big pieces of advice we give to patients and we employ even in healthcare settings is making sure that we have just some fresh air. And, this is some advice maybe your grandma could have given you, but, just opening a window, getting that ventilation going through, especially in a nice spring environment, that can do a lot to clear out these aerosols and droplets that are hanging around in the air. If you do have an infectious patient in your household, you do want to try to make sure that you're setting up that environment like in an isolated room so that airflow is going out of the room. So if you can set up a fan in the window to blow, just their exhalations and their coughing, blow those viruses out of the window so that if you do crack the window, it's not blowing them into the house. And that's the best advice I would have.
Well, that's a great point. That's something I never would have thought to ask about, so I appreciate that. That's not coming up in anything that I've read, so I appreciate that. Dr. Abernethy, I appreciate your time. And again, thanks to Science Line for setting this up. This is Howard Owens with the Batavian, and I'm not sure what we have coming up in other live stream interviews today, but I'll work on getting something going. And, of course, we'll have more coverage of how this is impacting our communities as the day goes on. Again, Dr. Abernethy, thank you very much.
Quite welcome. Thank you.
Bye.